Thank you, Gaurang Bhai, for giving me an opportunity to present this S1 in metastatic colon cancer. S1 is a novel oral 5-FU derivative widely used for treating gastric, colorectal, pancreatic, lung, head and neck, and breast carcinomas. It is designed to enhance the clinical utility of an oral 5-FU and is associated with low GI toxicity. It consists of 3 pharmacological agents at a molar ratio of 1:1:0.4, contains 3 components: Tegafur, which is a prodrug of 5-FU, Gemarasil, which inhibits the activity of DPD, and Oterasil, which reduces the GI toxicity by inhibiting OPRT enzyme. Composition and doses of S1 in MCRC. Each capsule of S1 contains either 15 or 20 mg of Tegafur, Gemarasil of 4.35 or 5.8 mg, and Oterasil of 11.8 or 15.8 mg respectively. S1 is indicated mainly in adults with treatment of advanced gastric cancer in combination with cisplatin, and as monotherapy or in combination with oxaliplatin or irinotecan with or without bevacizumab for the treatment of patients with metastatic colorectal cancer, for whom it is not possible to continue treatment with another 5-FU due to hand-foot syndrome or cardiovascular toxicity that developed in the adjuvant or metastatic setting. The proposed dose in MCRC for monotherapy is 30 mg per meter square BID from day 1 to day 14 with 1 week of rest. For combination therapy with oxaliplatin or irinotecan, 25 mg per meter square BID from day 1 to day 14 followed by 1 week pause. The maximum tolerated dose of differed between Asian and Caucasian population. It varies between 80 mg per meter square and 25 mg per meter square respectively. Perhaps it is due to differences in genetic makeup of CYP2A6 genotype enzyme. Next, coming to the mechanism of action of S1. As we discussed, S1 contains 3 components: Tegafur, Gemarasil, and Oterasil. Tegafur is prodrug of 5-FU, and Gemarasil inhibits dehydrogenase enzyme, thereby inhibiting the catabolism of 5-FU and its inactivation. And Oterasil inhibits OPRT enzyme, which is basically present in gastrointestinal mucosa. And these two conducive environment creates the increase in the dose of concentration of the 5-FU in tumor tissue, thereby increasing the anti-tumor activity of 5-FU. As Tegafur is a prodrug that is converted in the liver by cytochrome P450 to 5-FU. 5-FU is then actively catabolized by liver microenzymes. About 90% of 5-FU is converted to inactive metabolites by enzyme DPD. Hence, remaining 10% would be responsible for anti-tumor activity. S1 owes its anti-tumor properties to the production of 5-FU, which is gradually converted from Tegafur, following an oral administration of S1. Both Gemarasil and Oterasil act as biomodulators to impart better anti-cancer effect of 5-FU and do not have any anti-tumor activity by themselves. Gemarasil inhibits DPD enzyme that is responsible for inactivation of 5-FU and is 180 times more active than uracil in vitro. Oterasil, which is orotate phosphoryl transferase inhibitor, is found in higher concentration in GI tract, which helps in decrease formation of 5-FU nucleotides, that is metabolites, thereby decreasing the GI toxicity, mainly diarrhea, nausea, and vomiting, and stomatitis. Tegonate, which is produced by Natco company, which contains Tegafur, Gemarasil, and Oterasil. Tegafur, actually, it is there is a twofold increase in the concentration of 5-FU in tumor tissue, and Gemarasil, which inhibits DPD, and it is more potent, 180 times more potent than uracil, which mimics the continuous infusion of 5-FU. Oterasil, by inhibiting phosphorylation of 5-FU in GIT, decreases the gastrointestinal toxicities and low hand-foot syndrome as compared with capecitabine. And this is the diagram showing Tegafur, and this one. Gemarasil inhibits CDHP enzyme, thereby decreasing the hand-foot syndrome, neurotoxicity, and cardiotoxicity. And this one, Oterasil inhibiting GI tract OPRT enzyme, and it increases the tumor concentration of 5-FU, thereby increasing the cytotoxicity of the drug. And there is slightly increased bone marrow toxicity in form of thrombocytopenia, neutropenia, and anemia. in one of the paper which has been published in ESMO Open in last 2 months before, continuation of treatment with S1 after cardiotoxicity and capecitabine or 5FP based treatment. In this study, almost 200 patients who were taking capecitabine or continuous IUFU or bolus IUFU. These patients, almost 50% had previous cardiovascular comorbidities, and these had cardiotoxic events, almost 228 events in 200 patients in the form of chest pain, coronary syndrome, arrhythmias, heart failure, or cardiomyopathy, cardiac arrest, malignant hypertension. These appeared within starting up 2 to 16 days of initiation of therapy. And these are almost in 56% of the patients. These are severe to life-threatening conditions and led to permanent discontinuation of the drug, 96%. And after the discontinuation in the study, switch over to S1 was allowed. So after switching over to S1, almost 99% of the patients completed the intended treatment, that is S1, and only 4% had grade 1 or 2 cardiotoxicity. So in conclusion, switching to S1 based therapy is safe and feasible after cardiotoxicity and 5FP or capecitabine based therapy, and allows patients to continue their intended treatment, that is 5FP based treatment. And this is the largest patient series switched to S1 based treatment after cardiotoxicity and 5FP treatment. This shows 96% of the patients had no recurrent cardiotoxicity after switching over to S1, and only 4% patients had grade 1 to 2 toxicities. And this study shows S1 is feasible for life prolonging or life saving treatment when capecitabine or 5FP is discontinued due to cardiotoxicity. S1 as adjuvant chemotherapy in for stage 3 colon cancer, a randomized study, CC trial. Post-operative adjuvant chemotherapy for patients with stage 3 colon cancer is internationally regarded as a standard of care for improving survivals, while Western guidelines recommend IV, Folfox or Capax-based regimen as first line of treatment for adjuvant chemotherapy in stage 3 colon cancer. And this is the study which has been published in Annals of Oncology in 2014. And this study is mainly in stage 3 colon cancer patients. The dose used was S1 is 80, 100, 120 milligram per day according to BSA in 2 divided doses daily, and with 4 weeks on and 2 weeks off. And LV5 used 300 to 600 milligram daily according to BSA, and with the LV 75 milligram per day in 3 divided doses with 4 weeks off on and 1 week off. Conclusion from this study: so 3-year DFS was almost similar. 3-year OS was almost 93.6 versus 92. Risk of disease recurrence was reduced by 15% in S1 based therapy. Updated 5-year survival, which has been published in 2021. S1 and oxaliplatin versus Tegafur, Uracil, and Leucovorin as post-operative adjuvant treatment in patients with high-risk stage 3 colon cancer. Final analysis reconfirmed that SOX is, that is S1 and oxaliplatin is not superior to LV5 in high-risk stage 3 colon cancer in terms of DFS, with a median follow-up of 74.3 months. 5-year OS rate was similar in both groups, but 5-year OS rates in patients with T4 and N2B disease were favorable in S1 group, that is 64% versus 51%. And this is a non-inferiority study also. And we can replace 5FP or capecitabine patient Capax-based treatment regimens if patient is having more of neurotoxicity, this one cardiotoxicity, and hand-foot syndrome. A key takeaway is S1 is a new adjuvant treatment option that offers a lower drug cost and more convenient administration than LV5 and a lower incidence of hand-foot syndrome than capecitabine. Many physicians think that patients regard the complex LV5 treatment schedule every 8 hours, adding 1 hour before or after meals, as an obstacle, and the simpler S1 treatment schedule twice daily after meals to be a preferable. This study published in 2010. Irinotecan plus S1 versus Folpri as second-line chemotherapy for metastatic colorectal cancer, a randomized phase 2 non-inferiority study. All these S1 studies are basically studied in Japanese centers only because of non-availability of the drug outside Japan for a long time. In this study, almost 426 patients were eligible, 196 received IRIS protocol, and 203 patients received FOLFIRI regimen. IRIS versus FOLFIRI, median PFS was 5.7 versus 3.9 months. Median OS was 19.5 months versus 18.2 months. And patients who have previously undergone oxaliplatin-based regimens have resistant tumor cells with high ERCC1 and DPD levels, and thereby seem to be sensitive to S1 and irinotecan-based therapy. IRIS regimen in combination with DPD inhibitory PIFM may show superior activity against tumors with high levels of DPD as compared to FOLFIRI regimen. These are the phase 2 and phase 3 studies with the S1 and oxaliplatin in first line setting. Almost S1 and oxaliplatin versus capax regimen has similar results in the overall response rate and PFS and hazard ratio is 0.78, and even overall survival is also OS is also similar in both S1 and S1 based and capax based regimens. Even in along with bevacizumab also. All the response rates are same. S1 plus oxaliplatin versus capecitabine plus oxaliplatin for first-line treatment of patients with metastatic MCRC patients. This is also non-inferiority phase 3 trial. Response rate was almost 46%, and disease control rate was 81%. And median PFS was 8.5 versus 6.7 months. Median OS was 21.2 months. The risk of death is reduced by 18% in SOX regimen. SOX regimen could be an alternative first-line doublet chemotherapy strategy for patients with MCRC patients. These are the first-line S1 plus irinotecan-based regimens in MCRC patients. Almost S1 plus that is irinotecan or CPT11 has similar first line overall response rates in the range of 50 to 70%. Along with even some studies are phase 2 studies are S1 with irinotecan plus bevacizumab, FOLFIRI plus versus FOLFIRI plus bevacizumab. These are ongoing trials. CC trial, this is already discussed, and CAPS, SALTO, and TRICLAR studies, mainly 3-year disease-free survival. And take-home message is monotherapy using S1 has achieved a high response rate in patients with CRC. This good response is due to the composition of CDHP, a potent DPD inhibitor in the formulation of S1. Treatment using S1 combined with oxaliplatin plus or minus bevacizumab and irinotecan has achieved promising results in terms of feasibility, safety, and effectiveness. Furthermore, S1 is an acceptable treatment as adjuvant chemotherapy for colon cancer. S1 provides an oral alternative to IV administered 5-FU in both metastatic and adjuvant settings. Thank you.
Thank you, Irappa, for nice lecture. So our last panel discussion, it should be by